and we'll be discussing the topic of adrenal insufficiency in critically ill settings. So we are going to see a broad variety of things and a lot of clarity of thought. So what is required in this is dissection of the topic and a clarity of thought. Recently I read this article which gives a very good clarity of thought on this topic, which is extremely controversial, right? As we'll go ahead, we'll realize that there are a lot of areas of deficiency in understanding. At the same time, it is extremely important, that it could be matter between life and death. So I think this article by one of the I think pioneers of critical care, especially endocrine critical care, that is Greet Vandenberg. This is an article from her group. So that is critical illness induced corticosteroid insufficiency. What is it not, and what it could be, right? So I'll suggest that we go and we can refer to this very nice review article on this topic. So what Greet Vandenberg says is that we dissect the critical illness in ICU in three groups, right? One is the stress dosing required for a patient with pre-existing adrenal insufficiency, which was either diagnosed or not diagnosed. The patient is a known case of adrenal insufficiency, but was not diagnosed, right? It could be an acute septic shock not responding to vasopressors. This is the second area. And the third area is what is known as CIRCI, that is critical illness related corticosteroid insufficiency, right? So these are three different clinical situations, and first of all, whenever you are dealing with this patient, you need to first see on which of these three buckets does the patient fit in, and then consider both the short term and long term treatment of this, right? Now, though this slide is not very visible, I think if you have just one take home slide, and I'll share this in the group as well. This is the one take home slide, right, which summarizes all the three things, right? So I'll come back to this topic again, this thing again and again. So what she's saying is that in the first group is a patient with pre-existing adrenal insufficiency, which comes with critical illness, in which case you give a stress dosing of hydrocortisone, which is typically 100 milligram bolus followed by 200 milligram IV infusion, or in our case we do either 50 milligram 6 hourly or 100 milligram 8 hourly depending on the situation. So basically you need to give a supraphysiological dose of corticosteroid to tide over the acute crisis, and then once the patient goes into a situation where the crisis is resolved, then you can go back to the previous dosing of the hydrocortisone, gradually tapered over whatever the patient is taking for a while. Problem with the first case is that a lot of the times it is not recognized, that we don't have that history, and especially like we have seen in Indian setup, a lot of these patients are not diagnosed. Even if they are diagnosed, people are not aware about it, and a lot of these patients undergo pituitary surgeries, have apoplexies, are on long standing steroid use, especially alternative medications, in which cases a lot of these things it's not recognized, right? So that is a problem. Second is an acute septic shock not responding to vasopressor. A lot of whatever data we have is from this particular segment, right? All this French study, cortical study, we'll discuss those studies, comes from this. In this situation, they say that in a refractory septic shock not responding to vasopressors, you can consider giving steroids, which helps, right? The third group is what is known as a CIRCI, and which is what we'll discuss in more detail. Now, in this situation, what Greet Vandenberg says is that you probably don't need to give, you don't need to give 100 milligram very high doses. They have suggested an alternative regimen with a smaller steroid dose, which I'll come to it, right? Okay, now why this topic is important and why there is a lot of controversy is that there are a lot of physiological changes that happen in the ICU, right? So one dictum in endocrine is that never try to assess an inpatient in ICU in the same way that you assess an inpatient or an outpatient in an OPD basis, because there are a lot of physiological changes that occur in an ICU setting, in a critical care setting. So when you talk about HPA axis in the ICU, there are a lot of things which happen. You can see from this chart. First of all, remember there is a physiological stress. So the physiological stress, remember there is in the hypothalamus, there is the corticosteroid releasing hormone, and then you have the ACTH. So the CRH increases to counteract the stress, right? So that is normal physiology. It's if you and me are also admitted to ICU, the same thing will happen, right? This is not just limited to patients. Secondly, and this is what leads to problems in assessment, is that there is reduction of cortisol binding globulin and albumin, which increases the free cortisol level, right? Now, this is the problem. What we assay in practice is the total cortisol, which includes the cortisol binding globulin bound cortisol and the free cortisol. So the cortisol binding globulin is reduced in ICU setting, right? That is the reason why cortisol levels tend to be in that sense lower. There is also reduced GFR, which increases the half life of cortisol. So that free cortisol is there, the half life also increased, right? Then of course there are inflammatory cytokines, and inflammatory cytokines have an independent mechanism of activating the cortisol. So it converts the cortisol inactive to cortisol active form peripherally, right? And then there is reduced breakdown of cortisol by regulatory enzymes. So these are all reasons why there is a physiological change in an ICU setting, which is not so in a critically ill patient, right? Your interpretation of ICU patient is different. Ideally, if we have a good assay for free cortisol, a lot of problems are actually solved. Like just like you have free T4, it helps us especially in pregnant patients. Unfortunately, we don't have a very good stable free cortisol assay, so we are dependent on the cortisol assay that we use in day-to-day practice, right? So again, like I said, free cortisol versus cortisol, we need to understand that there is a difference. And because most of the historical studies are done based on total cortisol, we don't have free cortisol as such commercially available, right? A lot of confusion really also arises from this situation. Then there is a important critical illness feedback loop as with regards to cortisol, right? And this is something again important to understand. So remember, like I said, inflammatory cytokines increase the cortisol, which suppresses the NF-kB transcription, which reduces the inflammatory cytokines. It's a cycle, right? So the inflammation increases cortisol, cortisol suppresses the inflammation, right? So that cycle loop is there, right? And there's a negative feedback loop which is existing in the ICU in a critical ill patient, right? So that again we need to be cognizant. So let's take a first case, and this is a case which we had published when I was a resident. Now this is a boy, this is a primary adrenal insufficiency case, right? So this is a boy who basically, had, this is what the guy looked like, right? So again, a trained eye would have picked up this child, this boy as having primary adrenal insufficiency, is very clear. Unfortunately, the patient came in the emergency. He came on day 1. That time, they didn't recognize what it was. They did some routine test and turned out to have a mild subclinical hypothyroidism. So somebody started the patient on levothyroxine. In 2 days, patient came with adrenal insufficiency, right? And then that is the time when we saw the patient, we said this is a adrenal insufficiency. The hypothyroidism was something which was less important. What was more important was the adrenal insufficiency. What this patient actually had was what is known as a Schmidt syndrome. That is, so you have autoimmune polyendocrine syndrome. There are various types, and the type 2 is what is known as Schmidt syndrome, where you have hypothyroidism, but more importantly, you have adrenal insufficiency. The adrenal insufficiency was not recognized. And what happens in such cases is that when you have hypothyroidism with adrenal insufficiency, you should always correct the adrenal insufficiency before you correct the hypothyroidism. Otherwise, when you correct the hypothyroidism, it increases the metabolism, and whatever remaining cortisol, that is also metabolized faster. That leads to crisis. That is exactly what happened in this kid, right? So this boy landed up in the ICU, right? And then with adrenergic crisis, so we had to treat the adrenergic crisis with supraphysiological doses of steroids, right? Now, these type of patients we see day in, day out in our practice here as well, right? So this is primary adrenal insufficiency. Adrenal insufficiency can be characterized into 3 groups. Primary is basically where you have the adrenal gland which is not functioning. So it could be because of, let's say, the patient has adrenal metastasis, right? We have seen a lot of patients with lung cancers with adrenal mets, or breast cancer with adrenal mets, right? Tuberculosis is a very important cause of adrenal insufficiency. Histoplasmosis, right? Important cause. So these are all important causes of adrenal insufficiency. A lot of the times, you would have heard about Waterhouse-Friderichsen syndrome, which is basically adrenal hemorrhage, right? Adrenal hemorrhage is also very, very common, right? And often unrecognized. So these are all conditions where the adrenal gland is disturbed. You have adrenal insufficiency. Then you have secondary adrenal insufficiency, where the disease is because of the pituitary gland, right? So this typically happens when you have either a pituitary infarct, right, which happens maybe because of an apoplexy, or you would have heard of a condition called Sheehan syndrome, or patient has undergone a pituitary surgery, right? So there is a hemorrhage in the pituitary gland, which leads to secondary condition. And the tertiary adrenal insufficiency is when you have the problem at the hypothalamus level. Most important cause in this situation is long-standing steroid use, external steroid use, right? So it could be, properly prescribed steroid, where like your rheumatoid arthritis patient, or maybe SLE patient, or maybe your long-standing COPD patient or asthma patient, where patient has been on steroid for a long time, or it could be possibly because of some cryptic use of steroids, which is very common in alternative medication. So these are something you have to be aware. Again, as a rule of thumb, I'll always tell you this, and I always tell this in every talk of mine. If a patient says that I took an alternative medication in which any inflammatory condition, asthma theek ho gaya, arthritis theek ho gaya, allergy theek ho gaya, always consider it is glucocorticoid or glucocorticoid type drug unless proven otherwise, and whether it is an alternative medication or whether it's a pure dexamethasone, it is going to suppress the axis. It is going to happen, so you need to consider that and keep that in mind, right? So in such cases, of course, how do you establish the diagnosis? So the first line assessment, sorry, this it's not, color is not contrasting properly, but the first line assessment is to do the cortisol, DHEAS. Both ideally should be done in fasting if you can, right? So 8 AM cortisol should be done. Now DHEAS is a little invention, which is a little hack of ours which we learned over a period of time, right? But I think that has literally, understanding that has changed our practice. I'll tell you a little bit more about it. Cortisol, if a baseline cortisol, ICU, non-ICU doesn't matter, if it's less than 5, it is more or less proven to be adrenal insufficiency unless proven otherwise. More than 12, generally in an ICU setting there are caveats to this, but in a generally non-critical ill patient it rules out adrenal insufficiency, but in ICU setting it's still a problem. So we'll right now in this situation ignore the upper limit. So if it's between 5 to 12, that is when we ideally you should do a ACTH stimulation, but the problem with ACTH stimulation is that there is the synactin which is very expensive and not easily available, right? It is intermittently available, right? So we use other hacks for that. So we devised a system where we can probably have one step in between, right, where we started doing a DHEAS. Now DHEAS, the good part is that it's the same, it's also a hormone produced by the adrenal gland, but it has a longer half-life compared to cortisol. Because it has a longer half-life, it's like HbA1c versus our random sugar, right? So it gives you the assessment of axis for a longer period of time. Secondly, it's a more stable assay, and third is that you can do it without fasting. You don't require technically, because it has a long half-life, you can do it without that. So what we calculate is a DHEAS ratio, right? So DHEAS ratio is the DHEAS of the patient divided by the lower limit for the age, right? So DHEAS levels change with age, right? So young patient will have a high DHEAS value, whereas an old patient, typically a 60, 70-year-old, would have a DHEAS value of only 15, right? So that value changes over age. So you need to know what is the age specific range. It is given in our reports, and if it's not, there are published data for that. So you need to calculate the DHEAS ratio, and if the ratio is less than 1, it suggests that the HP axis is compromised, that is patient has adrenal insufficiency, and it's more than 1.8, it rules out, right? Again, if you have the value between 1 to 1.8, that is the case where you do a ACTH stimulation test, right? So this is where you do ACTH stimulation. ACTH stimulation again doesn't require fasting. You can do it straight away, right? Directly inject the synactin, and again in a non-ICU, non-critical ill patient, if the value is more than 18, it rules out. Less than 18, it suggests adrenal insufficiency. But again here also you need to understand the limits in ICU are different, right? I'll come to that point when we discuss CIRCI, right? So this is the way in which you do a ACTH stimulation test, right? This is the yes sir, please.
So you go back.
Yeah.
Second slide. So this one, yeah. So are we measuring the ratio manually?
Yeah.
Or
So
it is printed in our
no, ratio is not printed in a system. We calculate it. In fact, we have we have our own EMR system where we have built it into the EMR system.
Okay.
So because we see a lot of pituitary patient, but we have this little software which we have made. You can see that you can calculate. We have put it for different ages, cutoffs, and you can actually
so
let's say
lower limit of the DHEAS
for the age and gender.
Standardized in Indian setting, or
It is it's a Western data, so we don't know the Indian data.
Correct.
But it gives a rough estimate, right? And the data, in fact, in this system we have actually used the data which was published in JCEM, right? Which actually is the source of a lot of the other data. But sometimes that is also not very well standardized. So it's still, in a sense, accuracy is still an issue in that, because we don't know, for Indians we don't know, right? But the point is that end of the day what we are seeing is that if it's less, it's less, right? That is the whole point, right? So
age range or a specific age?
Yeah, age range. So it's I think based on 2 or 3 decades, right? So it's about something like 30 to 40 to 60, 20 to 40, that kind of age ranges. So
by this, can we also detect empty sella syndrome?
Aram se.
Yeah.
Adrenal. In fact, DHEAS is one of the earliest signs. So there are a lot of patients of ours over a period of time where cortisol is normal.
Correct.
But DHEAS was low, and then we diagnosed. We said this is adrenal insufficiency. It turns out, right? So a lot of these cases, over a period of time, we have diagnosed. We can, right? So that's why it's a very useful test. We have a lot of patients. Just a few. Almost every day we see one. Somebody with a DHEAS of 1. This is adrenal insufficiency. You don't need anything else. I don't need. And if you do their MRI, turns out they might have an empty sella, These are partial empty sella. You give them glucocorticoids, they'll have hyponatremia and all that, right? I think in one of the earlier talks we had discussed this. We discussed hyponatremia, where one thing I had said that I'll come to this point. You can directly use, but I would say you'd use both cortisol and DHEAS. Right? So I think for the first time when making a diagnosis, we use both.
So what is the importance of that ratio, cortisol and DHEAS ratio? Is that
Not cortisol DHEAS ratio, DHEAS ratio only.
DHEAS by
So DHEAS of the patient divided by the lower limit of the DHEAS for the age, and the chart which I said, that is actually a published study, right? So there's a study where in fact quite a few studies, right, on the same, because once somebody came with the concept, other people also use the same concept, and a lot of studies on DHEAS now based on that also. There is a DHEAS cortisol ratio also, which is again something which is there. But the problem, like I said, is not DHEAS, problem is cortisol, because the cortisol assay is still not a free cortisol assay, it's a total cortisol assay. It's very difficult to, and secondly, cortisol, the problem is that it has circadian rhythm, right? So it changes during the time of the day, whereas DHEAS is more stable, so it gives you a more stable value. Cortisol, in an evening, maybe in you and me, maybe also a cortisol level maybe 4 or 5. Right. So again, sometimes it becomes very difficult to diagnose unless it's a good fasting sample, right? So that's the problem with cortisol. DHEAS being a more stable system, it gives you a better idea,
so when
right?
the patient is already on cortisol, DHEAS is more reliable.
Yeah, patient is on a hydrocortisone treatment also. In that case, also DHEAS can be better. That is also another use. Remember, you cannot assay a cortisol for a patient on steroids, right? Because there are two problems there. Yes, so there are two problems there. One is that when you're giving hydrocortisone, that gets cross reactivity is there. So the hydrocortisone itself gets diagnosed in the system, right? That is something. So you would have seen cortisol. We have seen cortisol values of 60 and 70, which is basically, when I see this, I know that steroid दिया था और उसके बाद ऐसे हुआ है, right? So more so that's why in such cases you would have seen us also ordering a DHEAS rather than so always, right? So and one thing I often say, whenever you have a hyponatremia in India, a very important cause of euvolemic hyponatremia is adrenal insufficiency. Try to rule it out, right? It's a very, very important cause. And another hack, which I'll come to this, is that remember in primary adrenal insufficiency, you will have hypokalemia with so we'll have hyponatremia with hyperkalemia, whereas in secondary and tertiary, you will just have isolated hyponatremia. Sometimes you might even have hypokalemia, because if the patient could be on a steroid like dexamethasone, then the potassium will also be low, right? So that again, we need to be aware, right? But so when you have a typical hyponatremia with hyperkalemia link, there is an aldosterone defect as well, in which case I always look at possibility of a primary adrenal insufficiency, right? Okay, so so other way of assessing the level of defect is you can do an ACTH level. Right, an ACTH level less than 20 generally suggests secondary or tertiary adrenal insufficiency. More than 100, it is generally primary. Now, if sir would remember, there was one patient who had thousands value, right? The values was in thousands. So 1000, it is 100% primary adrenal insufficiency. There is no differential diagnosis when you have a ACTH of 1000. It could be a ACTH producing tumor. That is the only differential diagnosis, right? In which case it will be very clear. Okay, so this is the point. That the point being that when you have a patient, the most obvious thing which looks very simple but it's not obvious is that the patient already has an adrenal insufficiency, comes with adrenergic crisis, and that is something a good history would of course tell you, but sometimes that history is not there, and in that case again you have to rely on investigations and other hacks, right? Now let's look at the second scenario, and this is the scenario where we talk about refractory septic shock. And see, the most research is from this area, but the most controversy in research is also from this area, right? The problem, see, the other two situations are actually very clear. This is a situation where you have a lot of controversy, right? And this is where all the number of guidelines written and number of guidelines which keep changing, right? So this is a core critical care area, right? Rather than so let's take a case, for example. So you have a 55-year-old male patient with severe respiratory symptoms, had respiratory distress, altered mental status, high-grade fever. The patient was admitted to the ICU with septic shock with a community-acquired pneumonia, a typical type of patient that you see, right? So he required intubation, mechanical ventilation for respiratory failure, had persistently low blood pressure, required fluid resuscitation and vasopressor, right? So they did a ACTH stimulation and they did the excess evaluation, but technically Greet Vanderberg says that you don't need this, right? And guidelines also don't recommend that. You don't need to, when you have a refractory septic shock. Don't try to assess it, right? You know the problem, right? Start treating. So yet they did a diagnostic assessment, but we'll keep that aside. They said that this is a refractory septic shock not responding to vasopressors, you give the patient steroids, the patient was given hydrocortisone, patient actually improved, right? Now, like I said, this is an area of controversy, and I'll talk about why the controversy exists. Generally, glucocorticoid in septic shock, routine cases you don't need it, right? But in refractory septic shock you require, right? That is the ultimate guideline. And what is refractory septic shock? That is those who have severe refractory shock with systolic blood pressure less than 90 millimeter Hg despite 1 hour of adequate fluid resuscitation and pressure support. That is what would be a refractory septic shock.
Now they've added last year.
Okay.
Noradrenaline dose also.
Okay.
So 4
Perfect.
nights. So
Yeah.
and for few hours.
Right.
So in the last update, apart from this, with fluid and noradrenaline dose for few hours.
That is
So
refractory
then,
septic.
that is quadruple. So that is an update from last year's guideline.
Great. So I think, so when you, the point being that when you have a refractory septic shock, you should consider giving a
Yes.
glucocorticoids. That's the idea. Again, another controversy, now I'll come to the trials, but the other controversy is should you give hydrocortisone alone or hydrocortisone with fludrocortisone? This is an area of controversy. Now, just to make it simple, what we need to understand is when you have hydrocortisone dose more than 100, hydrocortisone itself has mineralocorticoid activity. So when you are giving more than 100 milligram a day, you don't need to give fludrocortisone, right? But when you are tapering the dose, that is where the decision really comes in. Typically, when your dose is less than 50 and the patient requires fludrocortisone, then you must consider adding it. But when your dose is more than 100, forget about giving fludrocortisone. You don't need to give it, right? So that's the clarity on this topic. Now, why the area of controversy? Because you had two trials, historical trials, which are exactly the opposite in terms of result, right? So one was what is known as the French trial, where they actually found benefit, significant benefit of giving glucocorticoids, and the other was Corticus trial, where they found no benefit of giving steroids, right? Now, though the patients in both the groups were different, so in the first French trial, there were actually more sick patients who were enrolled early into the system, right? Within 8 hours, the other group was a more stable patient, slightly more stable patient who were enrolled at 72 hours of septic shock. So I think timing is very critical, and that is why the authors of French trial actually said that, you know, the problem with the other trial was that they enroll the patient much later, right? So then there is another trial called Approaches trial, which was from the same group as the French trial, and they looked at the 90-day mortality, and they again found that hydrocortisone plus fludrocortisone had benefit, right? So for sicker patient, and that's why, you know, the guidelines now say that, you know, when you have a sicker patient, consider giving steroids, right, with a refractory septic shock. So that is the area of controversy. However, the other controversy, however, is that when they started doing meta-analysis, they actually found no benefit of steroid. So it's again an area of lot of controversy. There is no clarity on this subject, right? Because there were two large trials with different type of patients will enroll. But having said that, we have all seen in clinical practice that a lot of the time refractory septic shock, there is benefit of giving steroids, right? And generally, how long to give is a question. Generally, they say give it for 5 to 7 days, and then should you taper? That is another question, right? So you're given, de diya, patient ko benefit ho gaya, but would you then consider tapering it? Well, what they say is that unless the patient has an adrenal insufficiency underlying, and steroid has been given for less than 7 days, you don't need to taper. You can stop cold, right? But if you're given it more than 7 days, or you're suspecting or you're knowing that the patient has adrenal insufficiency, then you reduce the dose by 50% and keep following the patient, right? So again, this is where you need to be careful. Otherwise, the patient goes back into the state where, you know, you slipped off in the state. So generally speaking, you know, this is something you need to be really aware about here, right? Now, third case is the case of.
I would like to interrupt in this
Yeah.
case. So we heard the cutoff limit of cortisol is also deferred. Like
I'll come to that.
normally-
I'll come to the cortisol. So this is where we'll come to the third situation, which is what is known as a CIRCI, right? This is where we'll discuss. So now the case 2 and case 3, the problem is that most guidelines on critical illness actually combines situation 2 with situation 3, right? We often mistaken CIRCI with refractory septic shock, which it is not. Greet Vanderberg specifically in that article has said that this is the major mistake which is made, and this is the reason why there is a lot of controversy in clinical trials, that we are mistaking refractory septic shock with a condition known as CIRCI, which is a completely different condition, right? And that is where, you know, the controversy really lies, right? So this case and the subsequent discussion will actually clarify what actually is critical illness, corticosteroid insufficiency. So this is a 67-year-old patient, critically ill, admitted to the ICU for abdominal sepsis with perforation, and he underwent multiple redo laparotomies resulting in open, abdominal situation. And still there was, patient was encephalopathic, dependent on vasopressors, mechanical ventilator, renal replacement therapy, opioid use, etc. So this is day 30. Also, the patient is, it's a typical, you know, long.
Jabuba.
Right? So we see this patient, right?
Classic example.
This type of, now when you see some of the reports where it will give you some of these things, right? Patient has mild, moderate hypercalcemia, some hyperbilirubinemia, right? And this is where they say that ab isme you need to measure cortisol, right? Because now I want to see whether should I give this patient steroid or not, right? And this is where you measure the cortisol. So they measure the cortisol here, and the cortisol level on day 7 was 28, on day 14 was 22, and then dropped to 8 on day 30. It's coming down, right? And then patient has persistently low albumin and corticosteroid binding globulin. So then again, you know, this is again the problem, right? Whether वो कम हुआ है वो CBG की वजह से कम हुआ है या actual कम हुआ है, that we don't know, right? And ACTH was measured, which was low to normal, right? So around 25. Now they did a ACTH stimulation test, and they found that there was low response, right? Now I'll come to the cutoffs which we are talking here. So what they did was they started the patient with steroids, right? Instead of giving this high doses of 100 milligram, etc., they give 40 milligram of hydrocortisone in the morning and 20 in the evening, and then gradually the patient actually responded and the vasopressors could be tapered off, right? Now the patient actually improvement in urine output, serum calcium concentration normalized, and the patient hydrocortisone was further tapered, and then at some level you could actually stop, right? Now this is basically CIRCI. CIRCI is basically critical illness related corticosteroid insufficiency, and which was Maric et al. Who first gave the terminology long time back. Now this is the current understanding of CIRCI. CIRCI is like, so your acute refractory septic shock is like a T20 match, right? Either you're 20 overs, right? Either you hit or get out, right? That's it. Either you take that snap decision of giving the steroid and saving the patient life, or you decide not to give steroid and pull it on. CIRCI is when you have the time to reflect and think that what the problem is, right? This is like a test match, right? Patient 30 days ICU mein hai. Now you decide, you know, whether you want to kind of treat, and this is where you have to investigate and consider a lot of things, right? So this is the diagram of CIRCI, right? When you're doing CIRCI, when you're thinking CIRCI, you should also look at other causes which could impact the you know, the corticosteroid or can lead to adrenal insufficiency iatrogenically, right? Now what produces iatrogenic adrenal insufficiency? There are drugs. And what drugs? There are 3 or 4 which are very notorious to produce. One is steroid itself, right? So patient has been intermittently given steroids for a long time, right? Diya hai nahi diya hai, especially your COPD patients, asthma patients, right? Second is etomidate, right? It is known to produce adrenal insufficiency, and your azoles, right? Ketoconazole, fluconazole, they themselves can produce adrenal insufficiency, right? So it could be that the patient is on an antifungal for so many days, and that led to the adrenal insufficiency, right? And then now the patient is having adrenal insufficiency which you are not diagnosed, and then you are not treating it, right? So that is the problem. So whenever you are assessing CIRCI, remember it's like a test match. You have a time to think and reflect, and then think and reflect and then treat the patient, right? So why does CIRCI basically develop? And this is, we don't understand this, but what the paper says, and which is very sensible, is that what they are saying is that, remember, this patient is in the ICU for the last 30 days. There is a incessant body's exogenous, endogenous excess steroid production, and a lot of this steroid is produced at a peripheral level. So remember, there is a peripheral steroid which endogenous, your HP axis keeps getting suppressed over a period of time. That's, it happens. It has been known, and physiologically it has been shown even in animal studies that when you have that inflammatory system, the endogenous HP axis typically suppresses, right? You would have also seen, you know, heard about condition like non-thyroidal illness, right? Sick euthyroid syndrome. You know, a lot of these patients, ICU, you start doing thyroid function of all your 20-30 day ICU patients, you will find a typical pattern. Your the T3 will be low, T4 will also start going low, TSH will be low. Right? A lot of times we get references for this, right? Immediately, the first thing we do is that non-thyroidal illness, right, or maybe steroid effect, and we just, you know, leave it at that. You know, we say we'll assess this when the patient gets better. So the point here is that there is a, because of the relatively long-standing critical illness, the endogenous HP axis is suppressed, right? Now suppressed doesn't mean you treat everything, but you assess that, right? Secondly, there is another theory that there is some amount of glucocorticoid resistance also that develops in these patients, right? Remember, somebody who has been on, you know, a very high level of endogenously produced steroids, right, now does not respond to smaller doses of steroid, right? So there is some amount of resistance which is being developed. When to suspect CIRCI? When you have a patient with long standing in ICU with these type of picture, when you have hypotension, unresponsive to catecholamines, ventilator dependence, unexplained mental changes, high grade fever, abdominal pain, electrolyte imbalance typically of hypoglycemia, hyponatremia we discussed, and mild hyperkalemia sometimes, and hypercalcemia, right? If you have this type of mild, you know, critical illness, right? You have neutropenia, eosinophilia. In fact, Greet also says that one of the early signs is eosinophilia. You start having new onset eosinophilia, that's where you start suspecting that something is wrong. Patient, is otherwise conscious, complains of nausea, vomiting over a period of time, right? So again, this is something you can assess in your rounds, you have time to think and reflect, right? And that is where here the cutoffs really come, and this is now part of guidelines. There are guidelines. This is now there. So when you are suspecting this is how you assess, right? And this is where the new cutoffs for ICU really come into picture, right? So what you do is you are suspecting CIRCI, you just do a random baseline cortisol. The random baseline cortisol, it's less than 10, it confirms adrenal insufficiency, and that's why I said in ICU cutoffs this is the cutoff you need to use, right? If it's more than 34, it rules out adrenal insufficiency, but again this is an area of controversy, right? The upper limit hamesha controversy, right? Technically you can never thoroughly rule it out, right? But assuming that you rule it out, right? More than 34, 10 to 34, that is where you do a ACTH stimulation test in this situation also. And in this cases, unlike in other case, you have to actually see the increment of the cortisol, right? And if the increment is more than 9, it suggests a good access, good response, but the increment is less than 9, it suggests adrenal insufficiency, right? So this is based on the current guidelines. This is there in the the critical illness guidelines, as well as there are a lot of other guidelines also which have shown this type of cutoffs. The values may differ. The upper limit I have seen, there are papers where I have shown upper limit of 44, etc. The other thing which is very important, which is not controversial at all, is that when they did this type of assessment, the other side, the left side where the values are actually low, these people also have the chances of the prognosis also poor, right? So it's actually a good prognostic marker also, not just the diagnostic system, right?
Can
so
you throw light on the current standard of ACTH stimulation test in our hospital?
Yeah, okay, I'll come to this, sir. So this is the how you diagnose critical illness adrenal insufficiency, and again standard guidelines still say that you give them stress doses like 100 milligram. But again, Vandenberg's argument is that this is a situation where you will have to then remember it's like iatrogenically or endogenously produce excess suppression, where eventually you want to remove the steroids, right? You don't want to produce that cycle even worse, right? So instead of giving high doses, you give 60 milligram a day. That is their limit, right? That's the difference they say in terms of treatment, that हम इनको 100 milligram TDS देते हैं, इसके बदले you give 100 milligram a day or you give 60 milligram a day. Give a lower dose and then plan to how to taper, because remember this is again a chronic patient in your ICU, right? So you have to then once the patient is responding, then you have to plan of how we are going to cut the steroid off, right? That's the idea. Coming to the point of ACTH stimulation test now.
We need to add the fluorocorticoid.
No, in this case you don't have to add fludrocortisone, right? Especially again because since you are anyways going to give close to 100, you don't. But if specifically if you have hyperkalemia and other, then perhaps you would have seen also my tendency to add fludrocortisone is more when you already have a patient with hyperkalemia, because then again I'm suspecting that perhaps there is a missed primary adrenal insufficiency, or maybe there is a induced primary adrenal insufficiency. Again, like I said, if you have azoles, right, they can induce primary adrenal insufficiency, right? So that is something where so if I typically see a hyperkalemia in this type of patient, my tendency is to add a fludrocortisone, because technically it does no harm also. So that is again somewhere where there is a little catch. Coming to ACTH stimulation test, now traditionally synectin was never available in India. When we were residents in Gangaram, we did not have synectin. So there was a in Armed Forces Medical College, they actually found a hack for this. There is a very old and completely useless drug called Acton Prolongatum, which was basically used by orthopedic surgeons for some reason. Basically, it never took off. Acton Prolongatum is technically a intramuscular ACTH, right? It's a synthetic intramuscular ACTH, which what was original use? Ferrin makes this, right? The original use was some use by orthopedic surgeons. So there's a guy called Abhay who said that if ACTH to ye bhi hai, right? So why don't we use this, right? It's an intramuscular, it's a multi-dose vial. So they actually devised the protocol of using that as an intramuscular ACTH stimulation test. Somewhere in 2008 or 9, they published a paper on this in JAPI, right? Which is something we were very lucky, because when we became residents, this was already available to us, and we started using this. And there are a lot of studies mainly from India where they were actually compared with the standard synectin test and found that it is as good, probably better, and it is cost effective because it's a multi-dose vial, right? So when I first came in this hospital, we devised the system. We already have that multi-dose Acton Prolongatum available with us. It is cheaper and it's easily effective, and whenever you want to do the ACTH stimulation.
IM or IV?
IM. You give IM because it is IM. It's an IM. It's a it's an oily preparation. So you have to give IM, right? So it is to be given IM. So
Then you measure?
single dose and 30 and 60 minutes, 2 sample we take. So baseline 30, 60, right? So, but because it's an IM and it was not, then Sun Pharma in India, on request of a lot of the endocrine community, actually came up by bringing Synacthin to India.
Wow.
So I think 2017 or 18, they actually came with Synacthin in India, the original thing which was available worldwide. So then we started doing the standard ACTH stimulation test. Synacthin was costly, 250 microgram cost about 2000 rupees. So it's costly, but at the same time it's not that costly, right? So it can be still एक single time ही देना है. We did a lot of ACTH stimulation tests using.
That molecule here as well?
Problem is right now there is a global shortage.
Okay.
Since COVID, there is a relative shortage of Synacthin. It is intermittently available, right? Earlier we used to keep 1 or 2 doses available in the hospital. Preeti would remember even ek baar, so a few, so then because there was lack of it, we could not store it. So now whenever there is something, we ask the hospital pharmacy to order it, but abhi to milna bhi mushkil ho gaya hai. So sometimes you get it. So the multi-dose vial, right? The multi-dose vial, that entire dose where you can do 10 tests costs 2000 rupees, right? Acton. And this one single dose.
Different codes here?
No. So
versus this.
no. So what we do is we have removed that, right? Because we had this. So what we do is we order the Synacthin separately and bill the patient separately for the Synacthin, and patient gets billed separately for the cortisol test as a pharmacy product, and the test gets billed separately as a. There is actually a code for ACTH stimulation test. We actually devised that code, which packages the entire thing. But because right, because of this, right, and again to tell you, since we started using DHES as a system, our requirement of a lot of the time ACTH stimulation requirement has been very less. And so in this system also, of course, this is the guideline. Though there is less data, I would actually put one step in the middle and actually start assessing DHES in that also, right? That is then the requirement for ACTH stimulation test actually goes away. So that's the idea. Again, the problem is. Remember, ACTH stimulation is also dependent on cortisol. Remember that cortisol assay, we already discussed the pitfalls of that. So that's the problem, right? So basically, to summarize, adrenal insufficiency is very important, right? A lot of the time, if you miss this, the patient dies. It's that important, So I think that is where the important thing really lies. It's more complex than we understand. That is again the issue, right? So despite this type of clarity, even then in clinical real life practice, it's even more complex, right? It seems good on paper, but not that easy, right? So you have primary and secondary adrenal and tertiary adrenal insufficiency. We already discussed what they are, and this is the diagnostic criteria which we use in mostly in outpatient or stable inpatient system, where we use 3 steps. Step 1 is do the baseline cortisol. Step 2 is DHEAS, and step 3 is ACTH stimulation. And then this is the important thing, right? That we need to ask ourselves which of the 3 situations are we dealing with? Are we dealing with a undiagnosed or diagnosed adrenal insufficiency? Are we dealing with a situation where you have refractory septic shocks, or are we dealing with a situation which is basically CIRCI, right? And CIRCI, remember, is a long standing thing, right? So that is where, and again, the point being here is that we need to, if you have a refractory septic shock, don't waste your time testing for cortisol and all that. De do usko steroid, right? If you are thinking of adrenal insufficiency, don't waste your time, give it, right? But CIRCI, you have the time to think, right? And isko dena hai nahi dena hai, right? And that is where you really can check, right? Remember, there are a lot of drugs that can lead to adrenal insufficiency in ICU, right? So it could be an iatrogenic problem, etomidate, azoles, glucocorticoids, opioids, including, remember, tramadol is very well known to produce adrenal insufficiency. So patients on tramadol for a long time, right? We don't do this, but a lot of these ortho patients, have been on tramadol. I've seen Ultraset being used like anything, right? But that also needs to adrenal insufficiency. And then CIRCI diagnostic criteria, this is what we discussed, right? So less than 10, more than 34, and 10 to 34 you do a stimulation, right? So thank you.
Thank you.